So, a very warm welcome to a brand new edition of the EuroELSO webinars. Today is a very hot day in Vienna, and I understand this is the case for most of over Europe. Nevertheless, it's great that you're joining today. We've had close to 230 applicants, which clearly shows this is growing. And today we're going to talk about echo in ECMO. We're trying to test a new format. In the first half of the webinar, Martin Balik from the anesthesia department in Prague, Czech Republic, will give a lecture. And then we will have a discussion together with Dirk Donker. And I encourage you to use the webinar tool to put in your questions that I will collect and forward to both of our specialists. And mainly Dirk Donker from Utrecht, the Netherlands, will then pick up your questions and also try to illustrate some of that and substantiate his answers by giving some more examples, and to do this really in a very interactive way. So if you have to run early because it's too hot or because some appointments, all webinars will be able to be downloaded at the website www.euroelso.net/webinars. And if you cannot find it for some reason, you can also look for it by looking for it in the YouTube channels. So thank you very much for joining today, and I would like to pass over to Martin, who will give the presentation. Thank you very much, Martin.
Okay. Good afternoon from sunshine-burnt Prague. I'm broadcasting from General Intensive Care and Cardiac Intensive Care Department in General University Hospital, and I'm pleased to offer you an overview of echo and ultrasound application in routine ECMO monitoring. Here are my conflict of interests. You see that no one is related to the topic I'm going to present today. The role of echocardiography and ultrasound is absolutely crucial. You have to check the patient's diagnosis and ask yourself, is ECMO really indicated, and can we proceed still without ECMO? Or you have to also decide where you are going to cannulate and what type of modality you're going to apply. Would it be VV, or is the patient rather for VA or VAV? Then you use the ultrasound to facilitate the cannulation. And once you start with the ECMO, the daily echocardiography and daily ultrasound is a prerequisite of a good quality of care. You have to calibrate the continuous monitoring you apply. With the echocardiography, you of course look after the ventricular function, and you control the hemodynamic status of patient, including of course checking of the cannulas. The daily chest ultrasound is also part of the routine, particularly if you wean patients and if you do your actually monitoring, including also other modalities, then ultrasound is of the paramount importance. During weaning of ECMO, you see the lung parenchyma, you monitor the hemodynamics, and without echocardiography, you can hardly proceed with weaning. Vessels are very important pre-ECMO and also post-ECMO when you have to check for deep venous thrombosis and decide on further anticoagulation or eventually a cable filter. Lungs are, of course, very interesting if you look at the follow-up, and of course it concerns also the heart. I would like to start with the VA ECMO, which is routine. In the insertion of the VA ECMO, you insert the drainage cannula typically into the IVC, somewhere to the proximity of the Eustachian valve, like here, and the return cannula goes into the descending aorta through the femoral artery as a part of the routine, we routinely insert the superficial femoral artery prograde cannula, like the Kruger safe, which is shown here. And here's the insertion under the ultrasound. You get the guide wire in, and here is the laminar flow, continuous flow of the return into the leg, which is cannulated for the arterial cannula. There are two prerequisites for ultrasound cannulations, and these are this type of distal cannulation, and of course the arterial cannulation in someone who hasn't got pulsatile arteries, as it's on a fully blown VA ECMO with no cardiac output that you cannot palpate, so you have to use the ultrasound to get the cannula in. Here's the example of a decision making based on the ultrasound. This is 5 o'clock in the morning, and you get a female after recurrent fibrillations who has been intubated and brought by ambulance to your department, and already with the fast ultrasound and echo, you see there's an extremely poor performance of the left ventricle, and the patient is clearly in cardiogenic shock, with the VTI taken here in the left ventricular outflow tract of 5 to 6 centimeters. Here is the concomitant ECG, and the patient is in a profound cardiogenic shock, and this is just 3 hours later, was the patient has been immediately put on the VA ECMO in the ICU, and this is an example of acute myocarditis where the biopsy is performed next morning already on running VA ECMO, and here's more typical 12-lead ECG in a patient with the myocarditis. There's yet something interesting on the left ventricle, which you see here. This is a spontaneous echo contrast already with a thrombus formation, as it is shown here, and this is something which we really hate to see in patients on ECMO, because poorly unloaded left ventricle may end in a thrombosis and needs drainage. And unloading of left ventricle on ECMO would be another talk given by Dirk Donker. I would like to stress that a sort of minimum cardiac output is something which we like to see even in patients who has been put on rest during the VA ECMO treatment. So we would love to see some cardiac output somewhere around 1.5 or between 1 and 2 liters. So there's no time to put the heart to a full rest, because it may end in a left ventricular thrombosis. And the unloading can be also secured by other means, that is a surgical vent, where you would apply a cannula through the left atrial appendage by sternotomy, of course, surgically through the mitral valve to the left ventricle. These days, we would probably rather stick to impeller, which is an axial pump, which is inserted through the aortic valve into the left ventricular cavity. And by providing flow somewhere between 2.5 or up to 3.5, or eventually thick impeller providing 5 liters per minute, you can unload the left ventricle and the pulmonary circulation. Another way how to do it would be an atrial septostomy, or in the beginnings of our ECMO practice some 10 years ago, we were still using a thickest ever pigtail being inserted into the left ventricle and connected to the suction line of the ECMO. Why ECMO and echo? If you think about, for example, patients in a shock, or actually patients with the cardiac arrest, and typically a patient with the out-of-hospital cardiac arrest, we prefer to take a cardiac arrest to ECMO rather than running with the ECMO somewhere out of the hospital. And the reason is that there's everything available, and also the echo. And echocardiography can be performed immediately in the form of a fate and fast, and can be extended for a proper echo anytime. And what you need to exclude at the beginning is a non-cardiac cause of cardiac arrest. or a tamponade or aortic dissection or significant aortic regurgitation, which would be a contraindication to an ECMO insertion. You can also have a look at the available literature. I suggest to look at the Dirk Donker's paper published last year about a key player of echo in procedural guidance, tailoring, and monitoring. There are some specific populations in the ICU, like septic patients, where functional monitoring, including echo, seems to save lives. And the development of the changes of left ventricular and the heart function associate with eventual indication to ECMO. So the critical question which you ask yourself and deciding in this, I would say, non-primary indication to VA ECMO, non-primary, because you ask yourself in the septic shock, what is the adequate cardiac output for a given degree of decrease of systemic vascular resistance. So in patients who have a hypodynamic septic shock like this one, which actually associates with the left ventricular dysfunction and low cardiac index, that is quite clear that we would provide a bridge to recovery, and within a short period of time being bridged by the VA ECMO, your left ventricle recovers. And these patients have absolutely the best outcome of those of septic shock being indicated to VA ECMO. Simply bridge the period of a decreased cardiac output. You may have a patient who has got a high cardiac output. You can then chase the low systemic vascular resistance with the increased ECMO flow, and that has been proven on children with a lower body mass index, has become a part of the guidelines for the treatment of septic shock in children. In adults, it's becoming more experimental. It's actually the hypodynamic septic shock tends to hyperdynamic. But as for a hypodynamic, the survival rate, as is shown, for example, in the recent paper of the group Nicolas Bourret, is somewhere around 70%, which shows already case series from Paris from 2013. The echo and the imaging outperforms biomarkers in sepsis and septic shock. So just to give you an example, a patient who has got a normal heart performance, even with the decrease of all available biomarkers as is shown here, and even with unremarkable lactate, can develop shortly after stress cardiomyopathy in sepsis and septic shock with the cardiac index of 2.1 and a low cardiac output. And within a couple of days, just here between this point and this point, you bridge the patient on VA ECMO. This is the time point where the ECMO is extracted, and at that time the patient has got again a reasonable left ventricular function with a good stroke volume and a cardiac output. ECMO and weaning of the echo and weaning of the VA ECMO. There are certain prerequisites when you would consider the patient is suitable for weaning of the VA ECMO. So first of all, you have an unloaded left ventricle with optimum left ventricular and diastolic pressure. So simply you don't see lung congestion. And you can exclude the lung congestion by available markers. It's shown the E over E prime on the mitral annulus. And you can have a look at the interatrial septum and its position during the weaning. So here's the example of someone who has got a significant mitral regurgitation, a problem with the overall left ventricular contractility, with the low cardiac index, low stroke volume, and the significant gradient here on the mitral valve just shows that, and the density of it. This is definitely a moderate, at least moderate mitral regurgitation, probably almost a severe mitral regurgitation. You would have to see more planes. But then after 4 days here, you see patient who has got actually a nice performance, or much better performance of the left ventricle. It's negligible mitral regurgitation. His VTI of the left ventricular outflow tract here just fulfills the criteria of recovery of the cardiac output. His systolic tissue Doppler on the mitral annulus is much better, and the overall performance of the left ventricle taken by ejection fraction is improved. There's also not remarkably dilated right ventricle and no paradoxic septal motion. So this is a patient who has been actively weaned from echocardiography, weaned from ECMO with the assistance of echocardiography. When cannulating the patient for the VV, now we turn from VA to VV, you got two options. You can either cannulate double-sided, that is typically a drainage cannula in the IVC and a return into the SVC, or you can cannulate a single-sided cannulation with a double lumen cannula, which actually takes the blood from the SVC and from the IVC, like the Avalon cannula, and there's a jet just opposing the tricuspid valve. And it's very important to position the cannula under the echocardiography so that there's a correct return into the right ventricular inflow. This is an example of a double-sided cannulation with the drainage through the IVC, that is actually here, and a return through the SVC, that is from in the subcostal plane, this cannula here. You can freeze the image and measure the distance between the cannulas. The distance between the cannulas should be typically somewhere around 5 centimeters, should not be probably less than 3.5. If it becomes too close, you may get something which we call a recirculation. And when you put the color flow Doppler, you see a jet of the return cannula just hitting the Eustachian valve in the right atrium, and you see a good portion of the return goes into the IVC, is being sucked up into the ECMO, so you get an inefficient oxygenation of the right atrium of the right ventricle. So you get a high saturation in the circuit, in the drainage blood. What you have to do, you pull back this cannula, so now you see the color flow Doppler is not anymore directed towards the section cannula, to the drainage cannula, and this is what you like to see, is the systemic venous saturation in the range where you can exclude the recirculation. For the single-sided cannulation, is typically done with the Avalon cannula, which is here inserted through the SVC and the right atrium into the IVC, and you see there's a return going into the right atrium, just opposing here the tricuspid valve. You can monitor this by a transhepatic, transthoracic window, or you use the subcostal window, and not necessarily you need the TOE for this insertion, because what you have to provide is to put the guide wire into the IVC, and then you manipulate the cannula axially in the vein system and also by rotation to get this return just opposing the tricuspid valve. The crucial question when you arrive to a patient who is supposed to be a so-called VV, so you ask yourself, is this really ARDS? What's the filling pressure? That is the essential question that you should ask yourself in any patient in a respiratory failure in the ICU. So can I, with the manipulation of the hemodynamics, improve the lung performance and wean the patient towards actually spontaneous mode of ventilation, or eventually extubate him, or prevent intubation if he's not intubated? But this is for the severe cases. So you get an array of parameters, including transmitral Doppler and the lung, the pulmonary veins, and by a complex echo protocol, you decide, is this really an ARDS? So giving you an example, so this is a patient who had an alleged severe ARDS and was actually transferred to my unit for ECMO. He still made it even with these lungs without ECMO. And you can see that there's a very good left ventricular performance with the gross dilatation of the left atrium, which is here, that is some 82 mils. For a lady of that size, that represents a significant dilatation, 50 mils per meter of body square area. And when we looked at the transmitter Doppler, surprisingly, there is just an early filling with the deceleration time here. When we look at, due to the regularity of the rhythm, because I don't see any A wave, regardless of the nice sinus rhythm, when I look at the early relaxation of the medial mitral annulus and comparing the E over E prime, I see there's not only a dilated left atrium, but there's a significantly elevated left ventricular filling pressure. So this is probably a diastolic heart failure with the increased filling pressures and not an ARDS. And this is how it looked like 3 days later on diuretics propafenone for the rhythm, noradrenaline. Actually, this transmitter Doppler shows that this is just an electric sinus rhythm with a missing mechanical correlate. Sometimes the decision is difficult and needs some experience. So this is a 47-year-old manager with known heart problem, unspecified heart problem, which we didn't know when we arrived to his bed in the local hospital. And he had an influenza B with the nasty lung and with respiratory failure. So this is his actually first echocardiography, where you see a remodeled left ventricle, a chronic cardiac problem, which is here, with still preserved LVOT-VTI of 14 and a reasonable cardiac output. So what we did, we put him on, even with this ventricle, we put him on VV ECMO, and this is 7 days later, before the ECMO explantation, and here's the echocardiogram 7 days later, still with unremarkable mitral regurgitation and a reasonable cardiac output. So this is a picture of a chronic cardiac case who just suffered ARDS due to influenza. Now let's turn the attention towards right ventricle. It's very important to realize that a survival on the IPPV, particularly in the most severe forms of respiratory failure, is linear to ejection fraction of the right ventricle, which has been already presented in historical papers. And when you ventilate aggressively, you can actually make a lot of problem with the right ventricular dysfunction and with the rates of acute pulmonale. So with the limited plateau pressures, your incidence of acute pulmonale comes down, but an acute pulmonale as a complication of mechanical ventilation could be an indication to VA ECMO, even in patient who has got primary respiratory failure. I'm just giving you an example of someone who has got right ventricular failure in the D shape of the left ventricle, and who had to be cannulated on VA instead of VV. This is a combination of septic embolizations and an influenza lung, and this is the same patient just 5 days later. So the patient can then from VA be transferred to VV, which would be probably slightly more physiologic and less demanding for the circulation, but on condition that his cardiac output is back and the left ventricular and right ventricular performance is much better than it was 5 days before. The echo monitoring has also something to do with the cardioprotection, because you could have patient who has got large body mass index, a patient who is in hyperkinetic circulation, and may have a high requirement for an ECMO flow to secure the oxygenation. So we like to somehow match the spontaneous cardiac output of patient, which can be taken by echocardiography, maybe with the combination with continuous monitoring like this one, that is the pulse contour analysis. And we like to match it somehow with the flow of ECMO to actually provide adequate oxygenation. In patients with the hyperkinetic circulation or with the high BSA, you may get into problem with the low saturation even on highest possible ECMO flow, I mean blood flow. So what you can do, you apply a well-titratable beta blocker and you bring down the heart rate, and with the bringing down the heart rate, and your peripheral saturation comes up, because then the cardiac output somehow matches the output of the ECMO. It has something to do also with the size of cannulas, but one may argue that it has nothing to do with peripheral oxygen delivery. I agree, because this is more probably a cardioprotective measure, that by saving a couple of systolic beats, you improve the oxygenation, and it's more probably for cardioprotection. The vessels, a very important item. You should, if you can, even in emergency situation, to check the vessel of to check the caliber of the vessel and to decide on the cannula size. Because if you have someone who has got really profoundly shocked, you may need with the reperfusion a large large blood flow to supply the oxygen to periphery. And you also should exclude the, for example, deep venous thrombosis, which is here before the ECMO insertion. This is a non-compressible thrombotic femoral vein, and this is much better. This one is the other side of the same patient at the same time, who is much more compressible than this one, and there's a thrombus. Because what may happen, actually, that you, by incidentally, actually cannulating the thrombosed vein, you may get the thrombus into your ECMO set. Even worse, you can plunge it up into the right atrium and pulmonary circulation. So if you are with one ECMO set somewhere in the middle of nowhere in the countryside, you may get into big problem. The vessels on ECMO is actually a routine, and particularly after the ECMO, because there's a significant rate of thrombosis after the ECMO being withdrawn. This is a picture of the thrombose who actually floats into the IVC, and the thrombus has something to do with the drainage ECMO cannula, which had been positioned right in this place before. And this is another example. This is the same thrombus being measured. And this is a thrombus in the right arm with the thrombosed cephalic vein. And this is a junction in the cubital on the right arm. There's then an increased rate of anticoagulation and eventual indication to cable filter if possible. This is probably not the best place for cable filter. And important is also to consider that whilst most of the insertions are done by intensivists, we do all the VA extractions by surgeons, because there's always a thrombus between the return cannula and the prograde femoral superficial artery cannula. Even when the thrombus is very short, it can then embolize the femoral artery after the extraction. So we tend to insert the ECMO by ourselves, but the extraction is almost always surgical on VA ECMO. The VV ECMO can be extracted by actually pressing the vein. This is an example of a thrombus in the IVC here after the extraction of the VV ECMO, and it ended a couple of hours later, 3 days actually later, with a massive pulmonary embolism with the dilated right ventricle and the D shape, and with actually the urgency for the VA ECMO, which was immediately installed in this lady, and it was like a bridge to recovery, a treatment for the pulmonary embolism 3 days after the VV was extracted. Chest ultrasonography is something which goes hand in hand with the echocardiography. It's not only about pleural pathologies, also about the parenchyma. You decide on ventilation strategy and weaning, positioning, and proning. You can indicate bronchoscopy based on your actually clinical assessment and ultrasound, and decide on less or more aggressive mode of ventilation. We never aggressively ventilate whilst on ECMO. The fluidothorax and pneumothorax is something which is, I think, these days a routine in intensive care. You can quantify by separation in the transverse plane the amount of pleural fluid, like here on ECMO with the consolidated lung. You can exclude a pneumothorax. This is an example of a lung point, which has a 100% specificity for pneumothorax, and this is an emergency in any patient on mechanical ventilation. Just an example of a consolidated lung, and emphasizing that lung point is not everything. You should see also in the normal portion of the pleura a lung pulse, or you should see a comet. And because sometimes the lungs are so diseased that the pleural sliding is difficult to differentiate. So you need actually to exclude not only sliding, but also B-lines and a lung pulse to decide, is this a pneumothorax, or do I really have to look for a lung point? On ECMO with the consolidated lungs, the situation can be sometimes a bit trickier because the lung is consolidated and doesn't float as the aerated lung, so it goes down like a stone. So the fluid is sometimes more circumferential, and so there's a chance to underestimate the amount of fluid in the pleural space. And sometimes you see a lung point like a division between the pleural fluid and the air. This is a lung point between the fluid and the pneumothorax. And this is an example of fluid pneumothorax on ECMO. And this is just half an hour later with the chest vein being inserted here. And of course, you have a good chance the chest vein in between of the pleural layer, so you can scan with the linear probe the chest and just make sure that you put your chest in correctly and the chest vein correctly, and you got the adequate air equipment. So the position of chest vein is very important, and not only for the ECMO patients. Looking at the parenchyma, it's a normally aerated lung, or well aerated lung with the A line on a comet. This is an artifact, a Z line, and this would be a well aerated lung. When it gets worse, you get B lines that they wipe out the A lines. And when the B lines become more condensed or coalescent, then you get a third degree. And then with the fourth degree of alveolar interstitial syndrome, you get a lung which is like a liver. And what you see here with every inspiration, these little fingers here is the bronchogram. That's the dynamic bronchogram. This being just a confirmation that your bronchoscopy was fine and you open the bronchial tree, and now you need further treatment to improve the patient. You can create the lung recruitment score based on these findings of the quantification of the alveolar interstitial syndrome, and the most important message, and it correlates with the lung recruitment. But the most important thing is that the fourth degree of lung consolidation is probably not recruitable, and particularly when it's lateral or basal and caudal, you should not attempt a recruitment. When positioning a patient, your actually ultrasound can make sure that you are, with every inspiration here, getting the air to the place you like to have it, and it can make sure that your positioning is well received by the patient, and that you improve the ventilation and possibly even oxygenation. Bronchoscopy, if you don't have this, a dynamic bronchogram here, then it's fairly likely there's an atelectasis. There's a missing bronchogram, has a high specificity for it. And this is the same lung after 36 hours, which is now turned into some more coalescent B lines. Actually, you don't see as much. You get an air into the lung, which is good for the patient. Last not least, sometimes it's fairly difficult to monitor our patients, particularly in the early or middle stage of pregnancy, because cardiotocography is not applicable. So sometimes you, in those patients, monitor the fetal circulation by monitoring the heart rate by the bedside ultrasound. Sometimes you actually have to cooperate with the neonatology when you have a spontaneous delivery on ECMO, but this is very rare situation, by the way. This girl is now doing very well. She had some 650 grams when she was born directly in the adult ICU after the VV ECMO being connected. And I think I'm done for now, and I'm happy to receive your questions, and I'm also happy to receive pictures of our ECMO patients when they recover. And this is my invitation to London next year. Thank you very much.
Martin, thank you so much for your very stimulating talk. I very much enjoyed, especially all the hints and tricks and examples that you showed that can help us guiding the therapy for patients who are already on ECMO, and also the differential diagnosis and the indication considerations that you showed at the beginning of your presentation. Thank you so much. It's been really great. So I would like to encourage all participants to enter questions that we can pass on to our experts. And there is already a bunch of questions coming in. And Dirk, I'm wondering if you have some more practical aspects of real-time ultrasound guided cannulation strategies. Is there anything you can share with us?
Peter, can you repeat the question? Just I didn't get it properly.
Yes, Dirk. Dirk, I was wondering if you can enlighten us some more in detail on the practical aspects of real-time ultrasound-guided cannulation strategies for ECMO.
Yes, Peter. Before we go ahead, I just want to follow up on the presentation of Martin, and I would like to pose a question to Martin, which is related to the pleural effusion. So you beautifully showed that pleural effusion can be a significant problem, but when would you tend to drain under ECMO? Since that is, I think, a very crucial point.
Yeah, well, we have an idea that in an average size patient, the effusions around 300, 400 mils may become significant. So anything around half a liter and above can somehow limit, actually, particularly on VV ECMO, the weaning of the ECMO. There is also an important aspect of having a small pleural effusion in someone with a cardiac case on VA, because it somehow is autoregulation of the actually transmural pressure of the left ventricle, with the increasing of the pleural pressure by accumulating fluid in the pleural space. So not every effusion in a cardiac patient is suitable for drainage, particularly of this small or moderate size. It doesn't make a sense. There's also weighing risk versus benefit in someone who has been systemically anticoagulated. So you have to be very experienced, and we drain always with the blunt technique, using little blunt forceps just above the rib edge, and we don't use any sharp technique. Even the Seldinger technique with the sharp needle can be considered more dangerous than the blunt forceps. And for the
so we should probably be much more reluctant to drain pleural effusion in VV and VA ECMO patients in general.
Yeah, well, absolutely, because also the estimates for the very consolidated lungs, they don't perform as well as for the less consolidated lungs. So it has something to do not only with measurement of pleural space, it has something to do with the overall looking at the patient. So certainly the large effusions which approach 1 liter would be an indication for drainage, because that may completely hamper your weaning of the ECMO. And as you get more time on ECMO, you accumulate complications. So it's a very individual decision.
Right. So then probably I proceed with Peter's question, if you agree. So when you move, can you see my screen now on the? Can you move to my screen? Right. Okay, so there is my screen. Just a second. So Martin already elaborated on the vascular ultrasound for guidance, and I will not touch on that. That is, of course, important. And the Regensburg group has shown us that it can be very crucial in VV and VA cannulation to visualize the vessels properly, and you might end up with your venous cannula in the carotid artery, as is shown here. But what is important to realize, I think, that echo is very central in ECMO cannulation in general. If you do it at the bedside, that can be the TEE or the TETE in femoral or tubular femoral two-side cannulation. Of course, it is important before you start that you evaluate the patient as far as cardiac morphology and geometry is concerned, and concomitant aspects that holds for VV and that holds for VA, as we have shown in this paper and summarized. But the most important thing is probably that you're well aware of the cannulae and the hardware that you're using. So, for example, this is a multi-stage venous cannula. But the question comes up, how does this cannula look on echo? This is the single-stage venous cannula that we generally use. And also here the question comes up, does this cannula look differently from the other cannula? And how is that for the cannulation procedure, and how is that for the monitoring situation? So what I showed here is how does a pacemaker wire, a transit pacemaker wire, look on the echo, and you can see that you can see very well actually where the electrodes are. So the question comes up, does that hold for the ECMO cannula as well, that you can make very detailed echocardiograms of the echo cannula? So I put an echo cannula into a water bath, and you can see here the guide wire, and that is of course quite straightforward. And here you see the echo image of a single stage venous cannula, obturator, as you can see here, combined with the single stage venous cannula. This is the image on echo. So if you compare that to the guide wire, it doesn't look so much different, and that is the problem. So this is the ideal world of a water bath, but in a patient it can be even more complex. So if you look very carefully, you can see here the holes of the tip of the single stage venous cannula. But if you retract the obturator, so again, this is the situation of the cannula with the obturator, but if you retract the obturator, then you can see that the image inverts. So you get an inverted image. So you should realize that the cannula look much different when you do the cannulation procedure in comparison to the situation later on when you monitor the position of the cannula. So again, the guide wire, and this is the cannula tip without the guide wire. But what is important, of course, during the cannulation procedure is where is the tip of the cannula in order to avoid any damage to the vessels or the interior of the heart. And you can see here, guide wire plus cannula tip, there is virtually no possibility with echo to know exactly where the tip of the cannula is. Here again, the multi-stage venous cannula, guide wire plus cannula tip. There is the tip of the cannula, and if you retract the guide wire, then you can see the tip, but it can be very, very difficult to visualize the tip, or virtually impossible, as we have summarized here. And it is important to realize that you can perforate the inferior cable vein or whatever structure in the central venous system or the arterial system, and you should be very, very careful and ensure that your guide wire is in the proper position. And in terms of anatomy, it's important to realize that the SVC, IVC axis is not a straight line, as you can see here. So you should assure that the guide wire is really high up in the superior vein, cable vein, if you advance the cannula from the femoral vein. The same holds for the single-side lumen cannula. This is the ideal world, actually, ideal anatomy of an advertisement, but it is not a straight line. So you should be aware that the superior cable vein axis leads, actually, if you go straight ahead, leads to an introduction of the cannula into the right ventricle. And you cannot easily access the inferior cable vein in some patients. So it's not a straight line, and the Rotterdam group has shown that the cannula can easily migrate into the right ventricle and even erode the right coronary artery, as you can see here. So it is very, very important to monitor the SVC, IVC, right atrial axis, and be aware of the catheter dimensions. It holds for the Avalon Elite cannula, but also for all other cannulas, that you're well aware what are the dimensions, what is the length, what is the distance between the different ports. And you can also use, of course, fluoroscopy periprocedurally in addition to echocardiography. And in this way, if you use fluoroscopy before you start the procedure and just put the cannula within the package on the patient and start the fluoroscopy, then you can visualize whether you will end up in a proper position and come up with an educated guess. So that is what I wanted to show you on the real-time monitoring of echo and the role of echo in the cannulation procedure. Peter, do we have any questions?
Yeah, there was a specific question, and you already touched the issue of positioning the Avalon cannula. One of our participants wants to know if there are any tricks or hints how you could use only transthoracic ultrasound in order to prevent malpositions.
Yes, I think that the subcostal access and really visualizing the inferior cable vein is the most crucial step. You would like to ensure that the guide wire is deep in the inferior cable vein and keeps that position. So what we usually do, we switch between the bicable view in the TEE mode, and at the same time, we use transthoracic echocardiography and visualize the inferior cable vein. So if you do not have fluoroscopy or you cannot transport the patient to a fluoroscopy suite, then I think the most crucial part of the procedure is assuring that the guide wire remains in the inferior cable vein. The issue is if you access with a very large dual lumen cannula, so let's say an Avalon Elite 31 or 27, then you will see that the support of the guide wire in the depth of the inferior cable vein might not be sufficient. And it might flip out if you advance the cannula. And of course, the advancement is a very crucial step in the whole procedure. And then you will see that when the guide wire leaves the inferior cable vein, if you continuously monitor the inferior cable vein. On the other hand, I've seen in some procedures that the guide wire remains in the inferior cable vein, but you get a looping within the right atrium. And that is what you will not see when you skip the TEE by cable view. So I think you should combine both, and ideally TTE, TEE, and fluoroscopy. That is the super safe imaging modality, I think.
Okay. There's another question which I think is very crucial. It's a very regular decision annually. And sometimes we admit patients who had been placed on ECMO in another place, and we realize that the cannula are too small to give the patient the support he or she needs, regardless of the mode of ECMO. So when you measure the diameters of a vessel, how do you approach then choosing the right size of the cannula?
Yeah, that's a very relevant question. I mean, in general, the venous system, I mean, is a relatively flexible system. So I think that by measuring the diameter of the vein, you can approach the safest way of choosing your cannula. What we have faced in, for example, CF patients who have a long-standing hospital history and intravenous catheters and central lines and portacats and so on for long-term antibiotic therapy, that these patients tend to have strictures in the central venous system, and then echo might not be sufficient. So if we have a semi-elective bridge to lung transplant in a CF patient, for example, we tend to make a CT scan, so an angiography, to see whether the whole venous system is patent. And surprisingly, or not surprisingly, you will find strictures there in some patients, or abnormal anatomy. And so in this way, you avoid very significant complications. And you have to realize that echo might not be sufficient, and it might not be sufficient to just measure the diameter. Although I think you can have a fairly educated guess on what cannula you might use. But the venous system is quite flexible. So a small diameter does not always mean that you have to stick to a small cannula. But it's taking a risk.
Okay. Any comments on how to choose the right cannula size for arterial cannulation, depending on the diameter that you measured?
So we didn't have to get the chance to talk much about LV unloading, but see, in general, we tend to use the smallest possible arterial cannula. So in general, you know, if you choose a large diameter arterial cannula in the femoral artery, you will need distal selective perfusion, and it is not always technically very easy to put in a selective distal perfusion percutaneously. So we tend to go for a 15 French arterial cannula if we think that the patient might be sufficiently off with partial support. So we tend to not to go for full flow VA ECMO in order to give the left heart sufficient afterload reduction, so not to overload the left ventricle. So in the old days, I think we tended to go for a full systemic support of 4 or 5 liters of VA ECMO flow, or even in peripheral VA. And then you need also a large arterial cannula, but we tend to go for a smaller cannula, and then you have 2 advantages. I think you kind of unload the left ventricle, run 2.5 liters of flow, and you might get off without a selective perfusion cannula. So we tend to go for smaller cannula sizes on the arterial side.
If I may add, unless there's a profound shock or prolonged cardiac arrest, because then you would expect a drop of systemic vascular resistation. And in this situation, I would go still for the thicker cannulas and secure the distal perfusion, because you would need higher VA flows to secure the systemic blood pressure. That would be my experience.
It's always the balance that you have to find in every individual patient, but that the circumstances will dictate the size of the cannula, not only the measurement of the diameter.
Okay, I would like to change the topic a little bit of the discussion and go away from the cannulation part. Martin has very nicely shown some examples and elucidated on how to wean a patient from VA ECMO by looking at the left ventricle and all the parameters he had shown. Could you give us just your approach when you think about the right ventricle, when you have a right ventricular problem, how to wean the patient from VA ECMO, or when rather not to wean? What are the alternatives?
Yeah, so well, in general, using echocardiography requires certain stratified and some protocolized approach to right ventricle. So what you have to see is the size of the right ventricle, the longitudinal contractility, the fractional area change, elimination of the paradoxic septal motion. You would love to see adequate pulmonary artery flow, collapsing vein system, which somehow wraps around the drainage cannula. So these are all situations that you would consider the right ventricle fit enough for coming down with the VA support, if we speak about the VA support. And of course, there must be a well-performing left ventricle, because the ventricles are in series, so you have to eliminate the high filling pressures or elevated filling pressures of the left atrium and of the left ventricle. So it's a part of the echo protocol, if I understand what you asked, because there was some noise initially in your question.
Yeah, I think interesting in this context, if I may add, I don't know if my screen is visible now, is the what has been proposed in some papers. I don't know. Can we switch to my screen again? Okay, it's gone. Just a second. It's this one. Can you see it?
Yes.
It's the pump controlled. Where is it? Just a second. It's the pump controlled retrograde trial off. So we have we do not have much experience with that. We have tried that a couple of times, and it is feasible. But what is done is actually that you turn around the flow. So you let actually the patient pump through the ECMO circuit in the opposite direction of the support mode. And in that way, yeah, you have a possibility to evaluate left ventricular function and systemic circulation of the patient, but also the right ventricular function. And you can tailor the pump speed to the need of the situation. So that means that it is, of course, important to tailor the pump speed to avoid that the patient will perfuse the ECMO circuit instead of perfusing the body. But I found that an intriguing approach to weaning from VA, and I think that has not widely been adopted. Martin, do you have any experience with this?
No, I don't.
Okay, so as we are already close to the hour, I would like to give you my last question. Martin showed that the rate of thrombosis after ECMO decannulation is really high, and which would be the standard sites that you do the evaluation for the ultrasound? Because Martin had also shown some thrombosis going to the arm veins, so that would be my interest. What do you recommend?
Yes, I think. Yeah, Martin, go ahead.
No, I just wanted to say that a screen for the thrombosis is an absolute must, and we do it on the first day after the ECMO extraction. And if the thrombosis hasn't been shown before during the running of the ECMO, it must be excluded after the ECMO within 24 hours after extraction, or even less. So that's my point, and we search the limbs and the central type of prognosis as a central type of thrombosis directly in the big vessels like IVC, SVC, and so on.
Yes, I completely agree. It is very important, I think, to screen all accessible central venous vessels, since we all know that central venous thrombosis is a very crucial complication of VV and VA ECMO. So that relates to, I think, the femoral veins, the inferior and superior cable vein, but also the upper body central venous system. The question that remains, I think, so far is what is really the clinical significance of that? And Martin has shown us that it may be very, very significant. And we have not touched on the issue that we might also run into trouble in terms of infection of thrombus in long-standing ECMO support. So that is another important complication. And that might be very refractory as well. So I think we do not know in general what is the clinical implication of these complications, but we should be very, very alert and have a low threshold to check on that before and afterwards and after decannulation as well.
Okay, Martin, Dirk, is there anything more you would like to share? Anything you would like to mention finally?
Yeah, I think we have just a very limited amount of time, and it has been very nice to join you. But I would invite everyone who's listening to contact us if there are any questions remaining to the subject. I think we as a EuroELSO community have a low threshold, I think, and are very willing to help other centers and especially younger colleagues to share our experience. And that might not always be the best way to approach ECMO, but I think the important thing is to let everyone know that we are approachable and that we are very much willing to share our experience. I think that is crucial to advance this subject.
Yeah, I would add that you are always invited to post me some questions, and if I can, I would try to explain an answer which I could not squeeze into my presentation. Maybe the last message would be that the VA and VV techniques should not be separated, and the ECMO center should be always able to provide both, because you never know when you need various transfers between VA to VV or VAV or vice versa. Because if I hadn't been able to do it, I would have lost a couple of patients every year of those dozens I have every year on ECMO. So it's a key message to someone who wants to build a separate VV ECMO center.
Okay, so thank you both for making yourselves available and also in the future for our participants. Thank you so much for preparing this. It's a lot of work. Thank you for dedicating your time. Thank you to our participants. There have been numerous, there has been great participation. If you came in late to join the webinar, don't worry about it. The session is recorded and will be available in the website euroelso.net/webinars, or you will find it on YouTube, as all previous webinars are also. And as Dirk already mentioned, please save the date, May 6 to 8, 2020, EuroELSO in London. Please consider coming. It's always great to see the entire ECMO community and to educate ourselves. And finally, there's a special shout out to other webinar moderators who have been joining today. And I will see you on July 5th for a webinar on anticoagulation on ECMO. Thank you all for joining. Have a great day and stay cool. Bye-bye.